I'd like to thank Pyrexar for the opportunity to talk to you today and go over our experience with the thermal oncology program in the University of Maryland. That is probably, I would say, one of the youngest programs in the United States. We just initiated this program at the University of Maryland in 2013 when I moved from Duke to Maryland and to start this program. So this is just disclosure that I have been consulting for several companies, most of them are related to hypothermia. So what I'm going to do, I'm going to briefly go over biological rationale. You already hear this morning a lot about that, so I'm going to spend too much time on that. Just to mention that why hypothermia is working. It is cytotoxic. It sensitizes tumors to radiation, cell killing, as well as chemotherapy. It has very profound, and that's one of the uniquest features of hypothermia, very profound physiological effect on tumor which can be exploited. They are beneficial, such as increase in blood flow for drug or nanoparticle delivery. Has also very important role in changing oxygenation status of tumor. As you know, hypoxic tumors are radiosensitive and chemosensitive, and if you change that environment, you will have better response. That's very well established in preclinical and clinical studies. Emerging important role on immunological effects and way how heat can be used as a very powerful tool to induce some of these effects. We have to learn a lot about that, but potential is definitely there, and work from Rochester is actually spearheading that. And also we shouldn't forget that heat is very powerful in sensitizing notoriously resistant cancer stem cells that are responsible for recurrence or metastatic spreads of tumor. So there is a strong biological rationale to use hypothermia. And when I came to the University of Maryland, I actually realized one thing, that Eugene Robinson, which is a leader in our field, and this society very well recognized his work in the field of hypothermia, was actually working at the University of Maryland. So there is a very strong history of hypothermia at Maryland. Eugene Robinson was there from 1963 to 83, and he developed a lot of hypothermia research at the time. And first, as that was mentioned, I think with in Harris' talk, first hypothermia meeting was organized by Eugene in 1975. That was Symposium on Cancer Therapy by Hypothermia and Radiation. As this field was developing rapidly in 70s and 80s and 90s, you saw in the previous presentation there was decline in the interest in hypothermia in this country. So at the University of Maryland, last patient was treated in 2001. After 2001, there was no any more hypothermia treatment at this institution. So in 2013, about 50 years after Eugene Robinson started hypothermia, University of Maryland, we decided to renew that effort, and there was revival of thermal therapy, how we call it today, in Maryland. So we started in 2013 purchasing BSD-500 unit at that time, and started treating first patient in April of 2013. And we coined term external thermal therapy because you can also use same machine to do interstitial type of thermal therapy, which I'm going to mention a little bit later. So with the same system, you can do two types of treatment, external treatment and interstitial. Since we started in 2013 up to date, we treated 83 patients so far, which is, I think, probably, and anybody can correct me if I'm wrong, probably the busiest in terms of volume of hypothermia patients treatment site in the United States. I don't know whether any other site is treating that many patients just on this BSD-500. Obviously you have more machines and deep heating, you might have more patients. That's about almost 600 treatments. So with one machine, that's almost reaching capacity of your treatment, because you do this hypothermia treatment twice or 3 times per week. In 2014, in April, we treated first patient with interstitial thermotherapy, and up to date we treated 10 patients. I'm going to show you a little bit about that treatment as well. But I'm going to tell you a little bit for those of you that are considering or might be doing this, that to implement thermal therapy in radiation oncology or any department in the United States is not that trivial. So you have to have, obviously, on the first place, technical requirements. So you have to have space. You have to have dedicated space where you're going to put your equipment, and that always costs money. And hospital will ask you, is this space going to be used adequately, and are they going to make profit, obviously. So you need space, you need equipment, you need, more importantly, personnel. You need people that know how to operate this type of treatment. And you need very good documentation in order to get reimbursement. Otherwise, you're not going to get reimbursed from insurance company if you don't have documentation. Then you have to be very selective in choosing patients. They're going to be referred to you what you're going to treat, as you hear, and I'll tell you a little bit about that. Indication is very important. And you have to develop referral network of physicians that you can send patients back so they can see that your treatment was effective, and they appreciate what you've done for their patients, so they can refer more patients to you. And then you have to have well-developed treatment protocols that you know what you're doing for each of these indications. I'm going to go briefly through all of this. So equipment we have is BSD-500 system, which is FDA approved. So I can treat any patients with hypothermia radiation based on this indication. I'll tell you what protocol is that. There's no question about that. Every of those 83 patients that I've treated were not on clinical trial or any clinical protocols. They are just standard of care in our institution. So you can do that if you want in your place. Personnel, you have to have dedicated physician who knows how to use thermal therapy or hypothermia in the clinic. And also, for me, it's important to have backup. So I've trained 2 other physicians that can anytime step in and provide this service when I'm not available, or if they have their own patients. Physicists to cover thermal therapy service. We have 3 physicists that have been fully cross-trained, that they can move from radiation part of medical physics to hypothermia, thermal therapy, physics. Very important because they provide important technical support. And then you have the dedicated nurse, specially trained in skin care. When you're going to use this BSD-500 in conjunction with radiation and or chemotherapy, you're going to face significant skin reaction. And you'll be dealing with that, especially chest wall recurrence breast cancer patient previously heavily treated with radiation and chemotherapy. They're going to have significant skin reactions, so you got to be prepared to deal with. And I usually also have very good relation with wound healing clinics, so I can send patients, if that's necessary, to a wound healing clinic to take care of potential radiation burn and enhance skin toxicity with heat. And then you have therapists. In every department you have therapists that deliver radiation therapy. So we've decided, instead of have dedicated per one person, we cross-train 4 therapists so they can rotate around and provide treatment at a given time, so that you're not overburdening one person if you have too many treatments. Documentation, very important. And I'll be happy if anybody is interested in starting this to provide samples so you don't have to invent this documentation. It's all electronic medical records, compatible with ARIA, which is usually standard program in radiation oncology department. So you have to have prescription, you have to put simulation order. Simulation order not for radiation but for heat, because you're going to simulate patient before you start treatment to know what you're doing. Simulation summary after you put patient CT and simulate treatment, you need to know depth, because there are limitations how deep you can heat. You have to know area that you're going to heat. So this is all going to be determined by this simulation, which you have to document because there is a charge for that you can capture reimbursement. Physics consult order, special physics consult summary, again reimbursable documentation that you have to have in order to get this. And then treatment procedure note at the time of treatment and treatment summary at the end, which again will allow you to have reimbursement for this particular treatment. I think Rex actually did that. Rex is there. I took liberty, Rex, of putting this. You probably wouldn't be able to see. All these 83 patients. This is a very important point because for many years we were struggling in this country, and people say, I can't do hypothermia, I don't get reimbursement, I don't want to spend 1 hour with patient. This is, it's pretty unfortunate, but that's reality. This is all a cost-conscious type of cancer treatment. So if you look comparing a national average and those hospital charges versus freestanding facility, those are typical. I don't want to go in details, and this is what we have captured in Maryland. So there is not that much difference in terms of reimbursement. So every patient we treated, this is only one patient that I got pushed back from that particular insurance company that I have to do peer-on-peer, explain what I'm doing in order to get their reimbursement. I get more rejection if I do IMRT with radiation than with hypothermia. So whoever tells you, hey, there is a problem with reimbursement, at least in the state of Maryland that has not been an issue. Very important thing to know, and that's important for patients. Every patient we treat, we have a pre-approval through our office to make sure that they are fine, that they're going to be reimbursed. And you can crunch the numbers depending on the number of patients with this. You can easily return your investment of equipment, and the hospital is going to be happy because that's all they care. Patient selection, indication, referral. Again, what you can do with this machine is mostly superficial tumors, up to 3 cm, although it's approved up to 4, but I think up to 3 cm is a reasonable depth that you can hit any tumors on the surface. You can do head and neck, nose, breast wall, chest wall recurrence, melanoma, skin, sarcoma. I'll show you a list of all patients that we treated, very different indications, obviously. And indication for treatment is based on the clinical experience. So this is where I'm going to bring one point to you guys here in this room, because we've been discussing a lot. We have to do clinical trials. We have to do clinical trials to show whether hypothermia works. Let's do clinical trials. So when you think about indication, go back to 80s. And start looking in data that have been well published. Those are retrospective analysis. So those are not prospective randomized clinical trials. So that's a difference. If you're in business of treating cancer patients, everybody's arguing, can't use retrospective data. You have to show in prospective randomized clinical trial that certain treatment is better than another. But if you look in this, obviously there is thermal enhancement ratio, which tells you that with given dose, whatever standard dose of radiation, you're going to double your local control in different type of tumors. And from previous slides and presentation, that was pretty clear that this is something that happens all the time with hypothermia. However, still we have to prove that all the time. So I'm going to bring here this equipoise, and you know what that is. That's the dilemma for me, and I'll tell you what dilemma is here. This is parachute story. Okay, there was a paper that was published in British Medical Journal in, I believe, 2003. Parachute used to prevent death and major trauma related to gravitational challenge. Systemic review of randomized controlled trials. This is not joke. This is serious thing. Okay. So that this goes on. As for many other interventions, in this case, this is parachute. You can think about any cancer treatment that is designed to prevent ill health. The effectiveness of parachute has not been subject to rigorous evaluation, by using randomized controlled trials. That's true. Is that true? However, advocates of evidence-based medicine have criticized the adoption of interventions evaluated by using only observational data. I was showing you observational data before for hypothermia. So there are critics that say they can't approve something because it's based on observational data, not randomized trials. So the proposal was for those people that are most radical protagonists of evidence-based medicine to get organized and participate in double-blind, randomized, placebo-controlled crossover trial of the parachute. And I'll see how many of those people will get in that trial. So the reason I'm bringing this to you is my dilemma. that I have. I don't have dilemma, but people put me in this equipoise every time. I've been treating patients with hypothermia for 20 years. Terrible chest wall recurrence, patients that have failed all treatments. They would seen radiation once or twice, can't get radiation anymore, chemotherapy, anything, everything, they fail. The disease is raging on the chest wall. They don't have distant mets. They have a terrible chest wall recurrence, for example. Should I have a clinical trial to randomize them, put them in, again, treatment I know it's not going to work, radiation versus heat, then I can double local control. That's an ethical issue. Can't do that. I wouldn't be able to do that trial. I don't want to do that trial because for me there is no question here. So this is an important point. If we want to do a clinical trial, then we have to think, what are we going to do better than what we already know is working in this particular case? I'm not saying that for every other tumor site and every treatment, but at least for me, for superficial tumor chest wall recurrence, that's the case, because Gerhard just showed 6 randomized sites. 24. I couldn't fit them all here, so I took these ones. There's a phase 3 randomized trial, so that's the ultimate. And a number of them show clearly survival advantage, not only local control, but as far as the issue over external thermal therapy with superficial treatment, all these trials have shown improvement in local control. Gerhard mentioned that trial from Perez of 307 patients that unfortunately almost killed the whole field. And it killed it because it was a negative trial. There was no difference with 32%, no statistically significant increase in local control. But when you look at that trial, the quality thermometry, I don't want to repeat that. Gerhard has that nicely done. If you look in patients with chest wall lesions, there were 30% of them. Complete response rate was 62 versus 40 in favor of radiation heat. If you take a look in lesions less than 3 cm, something that's doable, you can heat those with the equipment at that time, 52 versus 39. That's pretty much what we're getting nowadays. A little bit less, but still more than if you lump all patients together in big trials, say it's not working. Well, for me, what's very indicative here that they report 30% in thermal blisters. We don't do that anymore. We got 10% max. So that tells me that they were really, what they were doing were heating too much on the surface. There was no thermometry. I don't know what, but there is a high incidence of this skin reaction. Again, another argument that trial was not done up to the standards should be done. And now we can go through all these subsequent trials, randomized trials in these patients. This is data for very well-known data from Europe and Canada, and always they beat us on these trials and always step ahead of US in terms of showing benefit of heat. And this trial show again what Gerhard showed again, 59 versus 41 in favor of combination radiation heat, complete response, but it's durable response again. Particularly important in patients that have been previously radiated. Those patients tend to respond to re-radiation very poorly. You can't give them full dose again. You have to be careful. So in those patients, you got 57 versus 31. Very significant difference in response. Again, 11% skin toxicity. Another trial from Duke, very well-known trial, randomized phase 3 trial, 122 patients. Patients that are not heatable and not suitable heat, they were taken out, so you end up with 103 patients that you then do heat and no heat, and you clearly see 65%, pardon me, 66% versus 42%. 20% difference in complete response. Again, patients that have been previously irradiated have significantly better response, 68 versus 24 if you do radiation again. Thermal blistering 10%. So what I'm trying to drive here is as far as I'm concerned, I don't want to do clinical trials with radiation heat versus radiation in those patients. Done. Over. Data here, experience, parachute story supports that as well. But I think that's the where we could go from there, we can do better. And we can do better if we add to radiation and heat, perhaps immunotherapy, heat shock inhibitors. There are drugs out there. Nobody does that. We should be doing that. That's the trial that we should do in the future. Why? I just want to illustrate how difficult that is, and that survival is not something that we should just think that that's obviously ultimate. We want to improve survival. We want to cure patients. But a lot of those patients are actually coming with a very devastating disease, such as chest wall recurrence. This is a very difficult situation to treat. I just skipped some of this. So, although a lot of patients already have distant mets, but a lot of them have this really very, very difficult chest wall recurrence situation when you have this raging cancer on the skin, and they have 60% of those patients have ulceration, bleeding, pain, very symptomatic, and very hard to deal with that. So I think that's where we can really make big difference and improve quality of life. Not only achieve better local control, durable local control, and palliation, help those patients to remove pain, bleeding, and that smell that is coming from that open wound is terrible for those patients, psychologically devastating. And I tell you, I've seen over and over those patients being so happy after we finish with treatment, because they were basically sent to us saying, their referral doctors say, nothing we can do anymore. So I think that's, for me, is extremely satisfactory thing to see, and very important one. So how we do that? If the tumors are superficial, we put this thermometers on the skin and measure temperature. This is the old applicator with BSD-500 that we used for a large area. So we need something conformal. We need Pyrexar, whoever is making device, to make this conformal so we can cover this chest wall that's not flat. And those are pretty clumsy applicator right now, I have to tell you. And so that can make improvement. Usually I don't go in the surface temperature over 43, maximum 44. Then you're entering in problem of thermal blisters and pain, and patient cannot tolerate that. If the disease is bulky, up to 3 cm, then we use CT or ultrasound guidance to put interstitial thermometers to measure temperature in the tumor as well on the surface. Very often those patients have mastectomies, scars, surgery, flaps. You have to be extremely careful, because people that don't have experience, went on to treat those patients, they would burn those flaps very easily, because the flaps don't have innervation, patients cannot feel pain, there is compromised blood flow, there is no cooling, and you can burn that flap in no time, even not knowing the patient comes next day and the plastic surgeon calls you, freaks out, what did you do to my patient? So you have to be careful, you have to measure temperature carefully when you're doing that, and make sure that you understand what you're doing. So this is what we've done so far, University of Maryland. Most of the patients, as I said, chest wall recurrence, those are the ones that we treat. We treat several patients who had neck tumors pretty effectively. A lot of sarcoma patients come to us, but those are patients that have extremity sarcoma or sarcoma that have been resected, and they are in high risk for recurrence. They have positive margin, and so that's where we use very often hypothermia. 3 to 3 melanoma patients, another indication. If you see, you got to educate your surgeon, send you those patients who have in-transit melanomas. It's very hard to control. Heat and large dose perfraction is very effective. It's been reported by Overgaard in 80s. A lot of skin cancer, squamous, basal cell carcinoma, anything on the surface you can effectively treat. Interestingly, treated 2 multiple myeloma patients that have gone through standard treatment for multiple myeloma, but end up with recurrence on the chest wall. Got radiation, didn't budge, didn't change anything. We used again radiation, heat, complete response. So for me, that's amazing. You try radiation, doesn't work. You try with heat, it works. So there's some biological changes there that make that treatment work very well. So, and some of this will be presented by my residents in this meeting in the next couple of days. Treated with, so this is all external thermal therapy, and interesting. Also, we treated some viral warts and condylomas. Those are induced with HPV. They responded to heat and radiation extremely well. and I presented that last year. We have paper coming out of that. So it's another indication that this treatment can be used. Interstitial thermal therapy, we started with 10 patients with different, predominantly with the GYN type of tumor, cervix endometrial carcinoma, and we do that in conjunction with the brachytherapy. So this device, BSD-500, you can use antennas to heat tumor, place them in the catheters that you use to do brachytherapy. So in order to do that, what you need to do, unless you can do it yourself, I don't want to do it, I'm not trained to do it, I'm not an interventional radiologist, you got to buddy up with a good interventional radiologist who wants to do that, who is not afraid to put those catheters in any place in the body. Then you can treat a lot of stuff. He's laughing, you know that. So Fred Mason is the interventional radiologist. So in this case, this guy had bladder cancer that recurred in the pelvis, standard recurrence, and has been treated with everything, anything, full radiation dose, chemotherapy. Now it's unresectable. Came to us and we re-radiated the external beam as much as we can due to guts toxicity, intestinal toxicity reaching that limit, and then we did brachytherapy with heat. So those are the catheters you put in the tumor, and then you can use those catheters to place in antennas to heat and thermometers to measure temperature around. So that's the treatment you can do relatively easily. This is, I think, vaginal wall involvement here. This is the cylinder, and then you have catheters that you can put to the template, again driving in your catheters for brachytherapy, and then again you can do a little thermal dose planning in this area and see what's going to be your dose distribution by playing with the frequency, with the synchronous and asynchronous type of heating, and if you have good physicists, they can do that, and then you can treat that patient easily. So that's our interstitial. I'm not showing you any data on 10 patients, but we did publish paper on interstitial as a case report on this particular gentleman that I show you. So I'm going to switch gear now and tell you a little bit about protons and thermal therapy, but not on the part that Dr. Datta is going to tell you later. I'm just going to tell you a little bit why we consider moving to that area in Maryland. So again, history is repeating to some extent. Just, I don't know whether you can read, this is a letter to Nature in, I believe, 1975, published by Eugene Robinson again. At the time in Maryland, he said that combined hypothermia radiation suggests alternative to heavy particle therapy to, reduced oxygen enhancement ratio. So at that time, he already knew that heat is very good to reoxygenizing tumor and removing this oxygen enhancement ratio or reducing, and that it can make radiation work better. But at that time, there was no particle therapy available. So he was, again, ahead of his time. So we just started treating first proton patients a couple of weeks ago and have 14 patients with proton therapy in the University of Maryland. Let me tell you why protons are superior to photons. Photons are about 15 cm in the body, and you have to irradiate, and so you're going to be dumping a lot of those before you hit the tumor, and also when you hit tumor here, you're going to be also having exit dose of radiation through whatever organ might be on the way. So you're going to be delivering a lot of radiation before and after surrounding tumor. When you use protons, the physical property of protons show that there is a Bragg peak, so it stops at the edge of the tumor. So it simply stops. So there is no exit dose, and the dose entrance dose is rather smaller as well. So that's the big difference. So just to give you a couple of examples to understand the concept where we are coming from protons and then thermal therapy in the future, and I'm sure Dr. Datta is going to tell you more about radiobiological rationale. I'm not going to talk about that. I'm just going to tell you a little bit about protons. So if you, I don't know whether you can appreciate, but on the top here, down bottom is the standard treatment we do with photons. And this is craniospinal radiation, which you usually do in kids. You're trying to irradiate brain and spine. And so you radiate from here, and you're hitting the spine, and then the exit dose is here. You see this red, those are high doses of radiation. They're exiting out. You don't want to irradiate lungs and heart and spinal cord, not spinal cord here, but the organs in the mediastinum. But if you use protons, you can completely avoid this exit dose. So you can really target it nicely, this to the organ. Same is, for example, here. Again, it's very hard to see on this picture. This is your standard treatment with the 3D radiation. This is IMRT, and this is proton. Particularly, I would like you to take look in this area here, which is oral cavity. That's where patients develop mucositis and have hard time swallowing and all these difficulties. Very hard to head and neck tumors too. So with protons, you can actually spare quite significantly oral cavity and other tissue as well. So I can go on and on showing advantage of protons. This is example again, protons and photons. Photons are here. You irradiate the dose, you're painting, you're bathing body in a lot of radiation. Using IMRT, you're delivering low dose of radiation to the big volume. That goes, again, with the risk of secondary induced cancers, and especially for young patients or patients who have a good survival. But with protons, you can really minimize this, and this is differential dose. So I think combining those two modalities might be very, very interesting for a number of reasons. And especially if we're going with development of non-invasive thermometry, that here just explained. So this is building that was built very shortly, in a very short period of time at Baltimore, in 110,000 square feet, 5 treatment rooms, and with a capacity to treat 2,000 patients a year. There is a hotel that's right now they're building next to this. It's a big investment just for building, 50 million. I think the total ticket price was close to 250 million, because you got to build this or buy this cyclotron and then gantries. And there's just some of the interesting information there. So this is how it looks like. So you have a cyclotron that accelerates those protons, and then you have magnets that are guiding these protons in the gantry. So we have 5 of those gantries. You don't see anything when you come to the room. It's all beautiful. But behind the wall is this huge gantry. It's very impressive to deliver this very precise type of treatment. So what makes this Proton Center, a number of Proton Centers, not many, but in the United States and in Europe, some of them have failed miserably. But what makes this center unique? A number of reasons. One would be that we use pencil beam scanning technology. It's a high-tech technology that's precisely, it's like on the printer, like a dots, delivers radiation very precisely to tumor. It's the second Proton Center in the US that have all this pencil beam technology. Some of them have this old technology with passive scattering, and this is your pencil beam that gives you capability to use proton the same fashion that we use IMRT, intensity modulated sculpturing way of treatment. So now you can imagine this with hypothermia. And what is interesting here, I'm just going to show you this slide. So you can, that Bragg peak that I was telling, you can spread this Bragg peak in the tumor, so you can get really pretty high dose precisely without exit dose. But one thing that makes it really exciting, to me at least, is this here. This is your nominal physical dose with protons, with the pencil beam. But radiobiological dose, and we call this RBE, relative biological effect, might be actually much higher. So for a given dose of radiation, let's say 1 gray, you're delivering 1 gray physical dose. But radiobiological might be 1.5 or 2 gray. Especially at the edge of this Bragg peak, and that's where this RBE goes high up, and that's becoming interesting to exploit this with hyperthermia. And Dr. Dara will tell you, they publish paper that I use often to quote to justify combination of radiation and heat. So what is available right now? We have a BSD-500 machine, and we have a Proton Center, but we would like really to get deep hypothermia system in the Proton Center, in our facility, so we can treat patients with proton, and the same very next door to have, because we have dedicated MRI 1.5 Tesla MRI, we would like to have a system that can slide in the magnet, and we can do what Gerard explained, non-invasive thermometry, very focused type of delivery, image-guided hyperthermia. So that's our goal, and we will be working very aggressively to achieve that through different venues of funding and collaboration to make this happen. We have already some drawings in our Proton Center where we're going to place the magnet is already there, it's fully operational, but we're going to place amplifiers and the rest of the equipment to make sure that this is going to take place. And that's the article that Dr. Datta published. Could hyperthermia with proton therapy mimic carbon ion therapy, and exploring thermoradiobiological rationale? So you should stay tuned to hear about that from him. I'm not going to talk about that, but it's a very exciting proposal, and I think it's worth of exploring. So what we really want to be, we would like to be the first place that have on one side thermal therapy and proton therapy. I know that PSI and RL have already clinical protocol, but they are physically a little bit apart. We would like to be one stop shop that we could do that. So we'll be working toward that. And maybe I can try to take some question, but I'm just going to run this at the end. Little clip, if I can make it happen. If not, this is our room that we have right now.
It's a touchscreen. It's a touchscreen.
It's a touchscreen. Okay.
There you go.
So this is how. So bear with me. It's just cartoon that shows how this is. So there is this table here. The patient is on the table. It's a highly sophisticated computerized movement. The patient is on that table because you got to get very precise treatment. So you do first, obviously, imaging to verify setup of the patient, identify tumor, and do all this stuff. And then once when this is over, then the gantry is going to start delivering beam based on the plan that was designed. So in this case, this is a cartoon or animation of the lung cancer, and the scanning beam is very precise in the way how it can deliver this treatment to this tumor, because it takes in account shape of the tumor. It can precisely paint the tumor. This is how this scanning beam. It's very fast. This is now going to take a long time. When in reality, when patient is there, it goes extremely fast, and treatment itself is within minutes done. So it goes on and paints this tumor. So again, for me, excitement is in the precision of protons. In the RBE, this radiobiological effectiveness potentially with protons, you can combine with hypothermia, which is known to inhibit DNA repair, reoxygenize tumor, and make this combination be ultimately very lethal for cancer. On the top of that, you can think about immunotherapy on these new approaches that can be beneficial, especially utilizing ability of heat to induce heat shock proteins and T cell trafficking and so on and so forth. So with this, I'm going to stop now here and just acknowledge my colleagues in the University of Maryland, physicists, physicians, nurses, and therapists that have been working with me on thermal therapy program. Thank you.
Question?
Will proton therapy ever be affordable?
It's going to be cost effective because the cost of proton therapy right now in our centers is equal to IMRT treatment. So the charge is same. So that's what we are doing. And all calculations have been done and projections to be able to do that.
So you're going to be able to recruit?
Yeah. Yes. Yeah. We'll be treating on the 5 gantries. Right now we have a long list. We just opened 1 gantry and already. So we don't. So the difference, I can tell you what concern was. There are proton centers that first of all don't use this technology. Second, they are open as freestanding facilities. not associated with any major academic center. So the referral is very problematic, and so you have an initial first year a very big increase in number of patients, and then you just start dropping down. For example, every Proton Center wants to treat prostate cancer patients. I'm a prostate cancer guy. I don't think that it's indication for prostate cancer. We're actually not going to treat prostate cancer. We're developing protocols to treat breast cancer, lung cancer. So it's a very different approach. The other difference is going to be in our center. Our center is open. So if you are a radiation oncologist working in private practice, you can come to our center, get credentialed. And if you want to treat patients with protons, the door is going to be open. You can come. Your credentials, you are trained to do proton therapy. You can treat your patient. You can follow up your patient back in your clinic. So we're not going to be there to take your patients away, because this is the only proton center in Washington, Baltimore area up to now. We are trying to work with other hospitals and physicians to make this door open for everybody. So I don't think that's going to be an issue in the future for us. Obviously, there is always risk. I didn't put my money in that. It's a private investment, so I'm sure they run some of this. Yeah.
Anything else?
I'm just curious, I have to ask.
How important is it to focus heat when used with protons as compared to photons?
Yeah, I mean, precision is important, like in anything. You want to be precise. But I think in terms of biological effectiveness, I don't think you should try to have, like in radiation, we're trying to have a very steep drop off the dose on whatever your PTV you want to treat. You don't want to treat normal tissue. You have to minimize it. With heat, I don't think you have to worry too much about dropping off that heat sharply. The other thing is that people start forgetting is for immunotherapy to work, and I think that's the future. What we are doing with radiation, we're actually not doing good things sometimes, because we are trained to irradiate tumor plus. That means lymphatic tissue around tumor. That's how cancer is spreading out. By doing that, we might be depleting T cells that are extremely important to come to the tumor once there is an induction of. So with heat, actually, you might be beneficial if you're doing more regional kind of mild heating. And I don't know, again, that preclinical data will have to prove that, but it's just in theory, my opinion.
How financially valuable is hypothermia as compared to proton therapy services running about $250 million?
It's all about marketing. And if you want to get patients, you have to have something different than other proton centers, I believe. So if we're all competing. I mean, we're in that business of competing for patients. We have Hopkins on the hill next door. And so, you know, if you want to have cutting edge in it's academic institution, we want to push the envelope. Cost is high, like cost was extremely high for linear accelerators. Remember when we were switching from cobalt machine to linear accelerators? Everybody's like, oh my God, that's so expensive technology, nobody's going to use it. Then we switched from 3D treatment planning to IMRT. Everybody was like, oh my God, it's so expensive, reimbursement, nobody's going to do it. My chair didn't want to do IMRT. Now everybody does IMRT. I don't know whether this is going to be the case with protons, but if you learn from history, if something is better, more precise, I think it's.
Is it essential that the hyperthermia system and the proton therapy systems are in the same building?
Well, that's a good question, Harold. It's something that we are doing. I don't know whether we have data. I know only data that I think it's from Jens Overgaard showed that the best effect is simultaneous delivery on heat radiation.
If you do it precisely.
If you do it precisely, but you can't do that. So intuitively for me, and again, I don't have clinical data to support that, it would make sense to do that as close to radiation as you can. Whether you're using biological effect of heat, if you have a big gap of a couple of hours from radiation heat, I don't know. The only thing I know that the oxygenation effect lasts 24 hours. I know that for an effect. I measured it in humans, 24 hours. But is this the only effect that you can count on? I think that's just one effect. There are some other effects. DNA repair. That might be a time-dependent event that we need to be there as soon as you have this damage, because DNA repair is going to take place quickly, and it takes, you know, if you're not there to inhibit those proteins, you're going to miss the boat.